Hi, everybody. My name is Tom MacGillivray. I'm a heart surgeon, and I'm going to be talking about adult congenital heart disease. So if you were born when I was born, and if you had congenital heart disease, certainly complex congenital heart disease, there's a very small likelihood that you'd survive to be an adult. But through the incredible work of pediatric cardiologists and pediatric cardiac surgeons over the course of my lifetime, that's gone from being almost a never event, living to adulthood, to an expected event. What has happened over that time, we've shifted from palliative heart surgery to what we thought, and I'll talk about that more later, as corrective heart surgery. Palliative heart surgery is you have no expectation of trying to fix the underlying disease. You're just trying to do physiologic manipulation. If there's not enough pulmonary blood flow, you create it with a shunt. If there's too much pulmonary blood flow, you narrow it down with a band. Reparative heart surgery, from a congenital point of view, is you do an anatomic reconstruction, but you leave residual lesions. So if you do a Rastelli operation and you have some kind of fancy conduit, that you leave behind something that's probably destined to fail, although you do repair the lesion. Corrective surgery, that's the holy grail. We almost never do that. Perhaps the closest thing to that would be to closing a patent foramen ovale, but you still leave behind scar tissue that can cause other kinds of problems. Through the success of congenital heart surgery, we now have more adults living with congenital heart disease than we do have children, which is a very interesting problem. So in these adults, we have several different ways that that these people present with their problems. New, previously undiagnosed lesions, the natural history of repaired or corrected lesions, the natural history of palliated lesions, and something that is now simmering and coming to a boil are patients with congenital heart disease who live long enough to develop acquired heart disease on top of it. Let's talk a little bit about some of these categories. So if you look really closely in this picture, you might see one of my old patients who was getting ready. She was a 32-year-old nurse practitioner who was getting ready to run her 6th marathon. And on mile 24, she collapsed. And she was fortunate to collapse in front of a paramedic truck, and also fortunate to be running with a colleague. They put the paddles on her. She had ventricular fibrillation, and they successfully resuscitated her. What she was diagnosed with during her workup was an anomalous aortic origin of her left main coronary artery. Why it decided to show up on her 6th marathon, mile 24, hard to know, but it did. And this is more than just an abnormal origin. These anomalous coronaries tend to have an intramural course. They have slit-like openings, and they have stenoses within the intramural course. As was identified on bread loafing. This isn't her. This is on a pathology specimen. What we've learned over time is that coronary artery disease, what's the big deal? You just bypass it, right? Well, what we've learned over time is that's not very effective treatment for these. If you do a bypass with a vein, if you do a bypass with an IMA, the likelihood that those bypass grafts will thrombose or stenose is very high, leaving you with the same problem, particularly in a younger person. What we've come to learn in these patients that they do well with unroofing of the coronary artery, that is going inside the aortic root, identifying the lesion and filleting it open and reconstructing a neo-ostium. This is a 3D CT of this woman with her reconstructed left main. It started originally from the right sinus of Valsalva here, and we reconstructed it so that it ended up essentially looking like a normal coronary artery. How about the natural history of repaired or corrected lesions, which I would say is probably what makes up currently the vast majority of our patients. Tetralogy of Fallot when I was a kid. That was described as the blue babies, but certainly had been known about long before me. Described initially by a medieval monk, Stenson, in the 17th century, and then given its name by a French physiologist named Fallot. And it's four things. You have an overriding conal septum that creates a ventricular septal defect, also narrowing of the right ventricular outflow tract, resulting in not only a shunt, but right ventricular hypertrophy. It was essentially a lethal lesion in childhood for most children. It was in the 1940s that the group at Johns Hopkins, Doctors Helen Taussig, who came up with the idea of reconstructing a ductus arteriosus. Dr. Blalock was the chief of surgery there, who some say took all the credit for all the work that was done by Vivian Thomas, who essentially proved in the lab that this could be done. And that revolutionized the care of congenital heart disease. But this was an operation not inside the heart, but outside the heart, where the subclavian artery was sewn to the pulmonary artery, again as a palliation to increase the pulmonary blood flow in these kids. They lived longer, but they didn't live long enough. The advent of trying to create a cardiopulmonary bypass machine, Dr. Lillehei, who was in Minnesota, many would consider the father of open heart surgery. He did 48 operations connecting children to an adult, using that adult as the heart-lung machine. And of those 48 kids, he had 28 survivors, long-term survivors, including some of those patients with Tetralogy of Fallot. Further up the road or down the road or across the road at the Mayo Clinic, John Kirkland is really renowned for, he and his colleagues, with really the making the heart-lung machine, refining it so that it could be reliably used in correcting Tetralogy of Fallot, much the same way that we still do now by opening up the right ventricle, patching closed the VSD, and placing a patch on the right ventricular outflow tract. The group at the Mayo Clinic, they looked at their 30-year results, and they demonstrated that they had very good long-term survival, whether they disrupted the annulus of the pulmonary valve or not. And although successful, the problem with that success is that what we've come to learn is that was an intermediate success, not a long-term success. Certainly when I was a resident in cardiac surgery, we were taught that pulmonary regurgitation, which was actually designed as part of the operation, you would, if they had a pulmonary valve, you would either disrupt it or resect it and leave these kids with pulmonary regurgitation, which I was taught wasn't a problem. They did fine, never have to operate on them. And that's what I was told. But what we learned was that's actually not true. That if you follow over time and sort of where those two curves start to separate was around the time of the curves from the Mayo Clinic. That if you waited a little bit longer, the degree of problems that was created by pulmonary regurgitation was significant. And that what the group in Canada had demonstrated was that we went from thinking that none of these kids would need to have their pulmonary valve replaced to thinking that almost all of these adults are going to need to have their pulmonary valve replaced. What's the best way to replace them? That's changed over time. Generally, surgically, we replace them with a tissue valve now as opposed to a homograft or a mechanical valve, finding that their durability and freedom from issues like Dr. Rule talked about less so. More and more, we're starting to fix these kids with transcatheter valves very effectively. How about the other, or the second most common cause of cyanosis, transposition of the great arteries? Again, another lethal disease in childhood where the aorta comes off of the right ventricle and the pulmonary artery comes off the left ventricle. So you have basically two parallel circulations causing cyanosis. The first open heart operation to fix this was a Senning operation, a very elegant but complicated operation where a series of rotational flaps inside the atrium were created to shunt or baffle the flow from the superior vena cava and inferior vena cava across to the left ventricle, so the blood would get pumped to the pulmonary artery, and the blood from the pulmonary veins would come outside of that baffle to go to the right ventricle and out the aorta. Pretty remarkable, since he described it in 1958, 3 years after the heart-lung machine started to be used. Dr. Mustard in Canada simplified the operation by making the same intracardiac baffle using a patch, but again, the concept being the same. The problem, as we came to find out, was that using the right ventricle as a systemic ventricle over time was not a long-term, or not a good long-term solution for many of these patients. The arterial switch operation was what we thought, again, was a corrective operation. You essentially take the transposed great arteries and you put them where they're supposed to be. You divide the pulmonary artery and the aorta. You move them around and you reimplant, you take the coronary arteries off and move them over to the main artery that they're supposed to come from, ending up essentially with what we thought was normal anatomy. Can you advance that slide for me? Oh, there we go. Yeah, with normal anatomy. And again, thinking that this was terrific, and there was a transition from predominantly atrial switch operations to predominantly arterial switch operations, thinking that we had solved the problem. We now have a bunch of people that are now either approaching or in their adulthood that have Sennings, Mustards, and arterial switch operations. What we've come to learn is they all have their own sets of problems. None of them was really a good solution. Certainly a better solution than what the infants had to start with. But they all have their own sets of problems that we have to deal with. The arterial switch operation, a number of these kids or young adults get pulmonary artery stenosis, probably because of the stretch, the tension on that anastomosis. Same reason with mobilizing the coronaries, and they can develop coronary artery stenosis and present with sudden death. And that, again, many of these young people in their young adulthood doing a coronary artery bypass operation is not a great solution. There are some intra-coronary enlargement techniques that we can do. The arterial switch operation, what we've also come to learn is many of these neo-aortic roots are prone to dilation and aneurysmal degeneration, which in and of itself is a problem, but probably more importantly is that change in the geometry can, and we think will, impact more and more the function of the aortic valve. And so what we're learning that we need to do in many of these young adults who have had arterial switch operations are valve-sparing aortic root replacements. Natural history of palliated lesions. These kids that were born with single ventricle lesions or heterotaxy lesions. In the 70s, Francois Fontan, who just recently passed away, demonstrated that you really don't need a right ventricle. You can take whatever single ventricle, whether it's a morphologic left or a morphologic right ventricle, and turn that into a systemic ventricle, and redirect the blood flow returning from the systemic veins directly to the lungs, ending up with what we now refer to as a total cavopulmonary connection. This is done in a series of stages. The first stage usually early in infancy or in the neonatal period, is creation of a modified Blalock-Taussig shunt, as opposed to a true BT shunt that they did back in the 40s, which was using the patient's own subclavian artery. You take a prosthetic graft and sew it from the innominate artery, the subclavian artery, to the pulmonary artery. After a year or two, you change that out for a bidirectional Glenn shunt, taking the superior vena cava and sewing that to the pulmonary artery in an end-to-side fashion, redirecting half of the venous return to the pulmonary arteries, and then ending up with the what we commonly but inappropriately refer to as the Fontan Operation, where through a number of different techniques, direct the inferior vena cava blood flow across to the pulmonary artery from the inferior aspect. Fontan did it just by sewing the right atrium to the pulmonary artery. There are intra-atrial tunnels you can create, or extracardiac conduits. It certainly was very effective at allowing these infants to become children and growing into young adulthood. Depending upon the underlying lesion, having a very good functional capacity. This is the long-term survival that was reported from the Mayo Clinic over time, which is, again, better than could have hoped when these kids were born, but still not as good as we would like it to be. There are a number of other sequelae that happen over time that we're coming to learn in adults that were born with congenital heart disease. Arrhythmias, up to 50% of patients that were born with congenital heart disease will develop atrial fibrillation by the time they reach the age 50 to 60. Heart failure is a common problem over time for a number of these lesions that lead to multi-organ failure and acquired heart disease, as we talked about. It's pretty interesting. If you do cardiopulmonary exercise testing on any number of these congenital heart lesions, including an atrial septal defect, a simple atrial septal defect, you find that their aerobic capacity is really dismal compared to patients without congenital heart disease. Our use of mechanical circulatory support in transplantation, the initial use of mechanical circulatory support in these patients, not that great. Left ventricular assist devices were designed for dilated left ventricles. They're not so great when you have a systemic right ventricle, but we're learning to place them in ways that they are more effective. Heart transplantation seems like a very good solution for many of these lesions, although there are a number of problems. These young adults have had multiple operations frequently. They're oftentimes very highly sensitized. They very frequently have high pulmonary vascular resistance, either as a consequence of their primary lesion or of their corrected lesion. Many of these patients who would benefit from heart transplants have significant liver disease because of the chronic congested hepatopathy. And what we learned is that patients that have heart transplants from a Fontan reconstruction have much poorer outcomes, certainly earlier on, compared to patients who have heart transplants for other diagnoses. But the bright light in that is that those patients who survive the early period of transplantation for congenital heart disease have a much better long-term outcome with their heart transplant. Adult congenital heart disease, as many of us were taught when we were doing pediatrics, children aren't just small adults. Well, as it turns out, adults aren't just big children either, that they have their own set of issues and problems that are unique to adults. In the early days, we'd take 30-year-olds and we'd put them in a ward next to a baby in a bassinet. And they'd be watching Teletubbies, not really a great way to take care of adults. These adults require adult specialists, not just in cardiology and cardiac surgery, but in hematology, in anesthesiology, in intensive care medicine, in the whole spectrum in order to appropriately treat them. And not surprisingly, that the outcomes in patients who are cared for at centers that specialize in adult congenital heart disease, they do better. So anyway, to summarize, we've had a tremendous success in treating children with congenital heart disease. Following, we now have more adults with congenital heart disease than children with congenital heart disease, which has created a whole set of challenges and problems. And again, adults aren't just big children. They do best, as we're finding out, in centers that specialize in adult congenital heart disease. So with that, I thank you very much for your attention.